Good morning, everyone, and welcome to today's webinar. Sponsored by the Northwest ATTC, the Pacific Southwest ATTC, and the Western States Node of the NIDA Clinical Trials Network. I'm Riley Vess, and I'll be your host for today, and we are very excited to have Dr. John Kelly from Harvard University here to talk to us today about stigma and addiction. A couple quick housekeeping things. First, if you have any questions for Dr. Kelly during the presentation, please put them into the chat box at any time, and after he's done speaking, I'll go ahead and read those questions to him so that he may answer them. You'll also be getting an email at the end of today's webinar that has a link to a survey in it. We ask that you please take that survey as it helps us to make sure that we continue to bring you content that you're interested in. That email will also have a link to download the slides from today and a link to the Northwest ATTC website where you'll be able to find a recording of the webinar later this week. Additionally, when you registered for today's session, you mark the type of CE or CME credits that you were interested in. For the CME credits, you'll receive an email with instructions on how to log into the Stanford CME portal, as well as some other instructions. This slide just has some information about the CME accreditation. If you selected one of the types of CE credits, you'll receive an email shortly after the session with instructions on how to receive those. And all of this information is in the slide, so there's no need to write anything down right now. And those of you who requested a certificate of attendance, we will receive that automatically via email in about a week. Okay, so on to the webinar. Today's speaker is Dr. John Kelly, and we are proud to say that Dr. Kelly began his distinguished career at the VA Palo Alto and Stanford University before he moved back east, first to Brown University and then on to Harvard. He currently holds the Elizabeth R. Spaulding Professorship of Psychiatry and Addiction Medicine at Harvard Medical School, the first endowed professor in addiction medicine at Harvard. He is also the founder and director of the Recovery Research Institute at the Massachusetts General Hospital and is one of the most influential scholars of addiction recovery in the world. Welcome, Dr. Kelly.
Riley, thank you so much. I hope you can hear me okay.
Yes.
Good morning, everybody. It's great to be with you all this morning. Thanks for having me. I hope this is worth your while. Let me just share my slides with you. There we go. Hopefully you can see those okay. And yeah, so I'll be talking to you today about stigma and addiction. Of course, whenever we talk about addiction, substance use disorders, we are talking about stigma and discrimination. And this is a big topic. It's a challenging one, of course, challenging ones to address for numerous reasons. And I will be kind of talking about some of those reasons as we go along this morning. Earrings here. There we go. So I don't have any disclosures. I just let you know that Riley mentioned that I am the director of this Recovery Research Institute. We publish a free monthly bulletin which summarizes the latest information on treatment and recovery research in a very usable, digestible, easy to understand format. So please avail yourself of that. You can sign up at recoveryanswers.org, that's the URL, and avail yourself of this free monthly bulletin. So what I'd like to do to begin is just zoom out a little bit. You know, here we are at this 50-year milestone since the declaration of the war on drugs back in 1971 under Nixon. And I've been reflecting on this quite a lot over the last couple of years, actually, just taking stock on really, you know, what have we learned? How far have we come? What have been the successes? What have been the failures of the last 50 years of this concerted effort, which really started under the rubric of the so-called war on drugs? And of course, one of the things I think that's happened, as I'll tell you, is a shift. There's been a broad stroke shift that we are witnessing currently away from the harsh, punitive rhetoric of the war on drugs and the policies associated with the more punitive stance of the war on drugs towards a broader public health perspective. Now that is reflected, I think, in the language that we use today, that we don't use, that was not used 50 years ago, and we've dropped a lot of the language that was used in concept. For example, back in 1970, Nixon famously declared that drug abuse, quote unquote, drug abuse was public enemy number one. Now, I don't think we use that language very much at all today. Instead, we tend to refer to these endemic problems as our top public health problem. And that is, I think, is indicative. It captures the essence of the change that has happened. That is also reflected in our legislation that has been passed in the last 50 years. Contrast the laws that were passed early on in the 70s and 80s, most notably the Anti-Drug Abuse Act, which had this enormous disparity in sentencing guidelines, mandatory minimum sentences at a ratio of 100 to 1, for example, with crack cocaine versus powder cocaine. And there was a tough on crime, tough on drugs approach in the 70s and 80s. This has shifted, of course. Now, let me just say, that also resulted, of course, in a lot of prison building because there was a great deal, a massive increase, 400% rough increase in incarceration between 1970 and 2000. We disproportionately incarcerate a much greater number of our citizens than do other countries. Contrast that with some of the more public health-oriented laws that have been passed in the last 20 years. For example, the Mental Health Parity and Addiction Equity Act and the Affordable Care Act, which focused on demand reduction, so prevention, treatment, and recovery support services. Also back in 2013, the Obama administration really underscored this shift with his first ever drug policy reform summit held at the White House on December 9th. I had the great honor and privilege of being there. But it really, again, marked this shift away from this more punitive rhetoric and stance associated with war on drugs to a broader public health-oriented one. We've seen also in the criminal justice system, of course, the birth of drug courts in 1989 in Miami, spread to Oregon, other places. The idea here, of course, is that incarceration is futile when we're addressing a public health or clinical problem that is driving the crime. It may be just purely a possession order that has resulted in criminal justice involvement. But the idea, of course, with drug treatment courts is to provide access to treatment for those people involved in the criminal justice system who have substance use disorders. Also, we've seen a shift not just in the criminal justice system, but also in law enforcement itself at the front lines, as police officers have recognized the need for different approaches in addressing endemic addiction problems, and of course, epidemic problems as well in the context of those endemic problems, as we've seen with the current opioid crisis. This guy, he's a chief of police in Gloucester, Massachusetts, made headline news a few years back when he implemented what he called the Angel Program, which was to help people who are addicted to help them into treatment rather than arrest them and lock them up. And this, again, you think about that 50 years ago, unheard of, this kind of approach that is reflecting this shift nationally in terms of our approaches to addressing these endemic problems. Not just nationally, of course, this has gone on, but internationally. I was in the United Nations back in 2020, presenting on this topic of stigma and discrimination in January 2020 in Vienna. Coming outside, I saw this monument. This is the only monument outside the United Nations building, historically a conservatively oriented international body associated with enforcing and implementing drug laws around the world and creating unified drug policies, which typically have taken the stance of the war on drugs. This was, I think, a monument which struck me as being hopeful and indicative, again, of a shift. It says, dedicated to all those affected by drug problems worldwide. Drug problems are preventable and treatable. Interesting that that is a monument outside the United Nations building of Office of Drugs and Crime. Again, I think indicative of a shift. We've seen, of course, more starker shifts in terms of policy positions, both nationally and now, both internationally and now nationally. For example, Portugal, back in 2001, implemented a national decriminalization policy for all drugs, designed again to try and address the crisis they were suffering from, opioid crisis back then in 2000, 2001. And we've also seen this shift now in Oregon, state of Oregon here in the United States, again, copying that same policy. It's not legalization. It's important to remember that decriminalization does not mean legalization. It's often confused with legalization, but it stops short of legalization. But it does mean that people do not get a criminal record for merely possessing and using drugs. And I think that is very important when we think of the burden associated with the criminal penalty when people are trying to recover from addiction, which can prevent them, of course, from gaining access to all kinds of services that can help them in their recovery journey. I like this graphic because it highlights these different policy positions and also highlights how nuanced policy positions can be. And it's not always how we might think of different policy positions that, that legalization or decriminalization is the answer. Because there are different harms associated with different policies. There are some sweet spots, as you can see in the bottom of this graph here, including decriminalization, market regulation, and prescription, and even legalization, but with many restrictions. You can see here on the two polar ends of this graph that both prohibition and commercialization produce high rates of health and social problems, but different kinds of problems. And so the question always with different drug policies is, who are the casualties going to be? And what is the frequency, what's the nature of those casualties, and how many of them are there? We've seen this, of course, with commercialization of alcohol and tobacco, and also now with changes in cannabis policy. Depending on what's done, whether there are many or few restrictions and greater commercialization. Again, to the extent a commodity or a substance is desirable to the human brain and is made more available, accessible, and cheaper, consumption will go up. And to the extent that it can cause harm, of course, harm will also go up. And this is what we've seen, of course, with alcohol and tobacco, and that we are starting to see with marijuana as more people are exposed to it in the population. In many ways, when we think about what's happened in the last 50 years, in many ways, we've gone from the war on drugs to the war on the war on drugs. And a lot of that, of course, has been associated with initially with those harsh punitive policies, but also we've learned a lot in terms of both in terms of demand reduction and harm reduction. Think about what we've learned just from the prevention, treatment, and recovery support services side. NIAAA, NIDA, SAMHSA began in 1970, 1974, 1992, respectively. Again, designed to understand the causes and impact of substance exposure and addiction, as well as how to implement treatments around the country and so that people can access them. And we've learned a lot about etiology, for example, that we did not know 50 years ago. And all of this does pertain to stigma and discrimination, as I'll describe in a minute, because cause and controllability really do have major implications for the degree to which something is stigmatized. Now, we have learned a lot about genetics, for example, that we did not know 50 years ago about addiction, that roughly half the risk for addiction is conferred by genetics. Like other complex disorders and diseases, It's a complex one. It doesn't mean that because you have a genetic predisposition that you are going to get the disorder or disease, but you are at substantially elevated risk. We've also learned about neurobiology in terms of controllability, another dimension of stigma, whether someone can control their behavior or not, or whether they're just engaging, for example, in willful misconduct at the expense of others. Now, we understand much more clearly about the nature and impact of substance exposure on the brain's neurocircuits and structure, and we can see this more clearly thanks to many decades of neuroimaging, which has improved in both quantity and quality. Also, epidemiologically, we understand much more about risk factors in the population, demographic and psychiatric. We also understand about the different pathways into, through, and out of addiction, the clinical course, what its duration is, and what we can do to shorten its duration. We've learned a lot about that. And also the different kinds of treatments that can help. Think about what we've learned in the last 50 years in terms of relapse prevention, motivational interview, and contingency management, medications, all these very potent, powerful things that can be replicated, implemented around the country, around the world to help people with substance use disorder. It does not mean, of course, that we've solved the problem by any means, but we've made substantial progress in all of these areas in the last 50 years. I think it's worth stepping back, taking stock at this milestone to look to see how far we've come, what we've done, what we've achieved, and what we still have to do. Now, in relation to that, of course, is despite the fact we've learned a lot about the causes of addiction in terms of its biomedical causes and its impact in the brain, in terms of its controllability, and the nature of it in terms of why it is, in fact, a psychiatric disorder, stigma and discrimination still persists. And this is why we are here, of course, talking about it. What can we do about it? Well, I think there are a few things that we can do, including decriminalization of drug use, as has been done in Portugal, as is being done now in Oregon. But also, these other three things have some evidence that they can help reduce stigma and discrimination for people with these conditions. Education seems to help more about, if we educate people more about the nature of these conditions, particularly clinicians. Personal witness, so that social contact with people who are in recovery or who have had a problem with drugs or alcohol tends to disabuse people of stereotype beliefs they may have about the nature of those conditions and the impact they have on people's character. And also changing our language and terminology. Why is that important? Because our language, of course, reflects and affects our approaches to these conditions. So what is stigma? Stigma can be defined as an attribute, behavior, or condition that is socially discrediting. And what is discrimination? Discrimination is the unfair treatment of individuals with that stigmatized condition. Of course, we see this time and again that people who have stigmatized conditions are discriminated against, and we see this as well in substance use disorder and its treatment. So just to make sure that you are not all robots out there, please see if you can correctly identify all of the pictures here which feature addiction treatment facilities and which treat other health conditions. Give me a second. Well, if you were to look at this for a little bit, you'd be able to see quite clearly, and I think most people will be able to tell which ones treat other health conditions, which ones treat addiction. Because there is typically, not in all cases, but on average, you can see that the quality of the physical environments in which people with substance use disorder and mental health, I would argue, are treated, tend to have a much lower standard. And I think the important thing is that people with substance use disorder actually may need better quality environments because they tend to have lost that self-respect and the dignity of being human, oftentimes as a result of addiction. So arguably, people with these disorders need a more dignified environment, not a less dignified environment. But people with substance use disorders often get treated in second-class, second-rate environments because oftentimes it's viewed as good enough for addicts, quote unquote. And it's good enough for them because they don't have real diseases or real disorders. So we can appropriate less funding to those resources because nobody really cares and they don't suffer from these real disorders. Again, that's an example of healthcare discrimination related to these particular disorders. And as I mentioned, I think one of the other aspects of discrimination that happens in recovery relates to the criminal convictions, because one of the things, if we've done one thing right over the last 50 years, is that we've learned. I always use this metaphor of a burning building when it comes to addiction, and I think of addiction as a burning building. And we've done a good job in recognizing that there is a crisis, that the building is on fire. And we've done a good job in the last 50 years at putting the fire out. That is to say, stabilization, detoxification, and acute care treatment, usually lasting from 30 days to 90 days. We've done a good job at that part of the picture. Where we've done less a good job has been fireproofing the building, preventing the fire from restarting, providing the building materials that people need to rebuild their lives, and also, notably, the building permit. And this relates to this notion of prior criminal records, as I was alluding to earlier, that prevents people from getting a foothold in recovery because they have a felony conviction related to drug use that prevents them from getting housing, getting a loan, getting a bank account, getting the kinds of things that people need, a foot in the door that can instill hope that they can get their lives back on track and build a future that's worth living. When that is denied to them because of a prior conviction, of course, that can be very disheartening when people are really climbing up that steep hill in early recovery. So what do we know about stigma and addiction? Well, there's been lots of studies around the world. This is one published about 20 years ago by the World Health Organization, looking at 18 of the most stigmatized conditions in 14 different countries. This included being a criminal, being HIV positive, as well as using illicit drugs, addicted to illicit drugs like heroin, as well as licit drugs like alcohol. Now, universally, across these 14 countries and 18 conditions, the top ranked, most stigmatized condition was illicit drug addiction. Number 4 out of these 18 was alcohol addiction. So very stigmatized conditions. 2 of the top 4 involve illicit drugs as well as alcohol. So these are universally stigmatized problems across different societies. We also know that substance use disorder, relative to other psychiatric illnesses, are more stigmatized. In part, it looks like because people with substance use disorder are viewed as more to blame for having their disorder than other psychiatric illnesses. So because it involves initial choice or decision to use the substance to begin with and maybe to reuse it, people are viewed as doing it to themselves and therefore not engendering as much compassion and sympathy or empathy. Now, of course, this is where genetics come in, because that initial exposure is modulated by our genetic predisposition in terms of its effect, profound effect on the brain and in the subjective experience, which leads to repetition and exposure, chronic exposure, and brain changes. I'll come to that in a second. Now, describing substance use disorder as treatable, as a treatable condition from which most people will recover, which is true, seems to help. So that idea of a treatable condition with a good prognosis seems to diminish stigma. And also patients who have the disorder themselves, who hold more stigmatizing beliefs about the disorder, are less likely to seek treatment and to discontinue sooner, irrespective of how severely impaired or addicted they are. We also know that clinicians and physicians, just like other members of the general public, are susceptible to biases and stigmatizing attitudes. And often viewing patients who have substance use disorders as unmotivated, manipulative, dishonest. But, as I mentioned, training, education does seem to help in the clinical realm in terms of reducing that stigma. And what that can mean, of course, is that patients can wait longer for appointments because clinicians don't particularly want to see them, and they can have shorter appointments and poorer quality care because clinicians don't think they're worth the time or deserve the time, like real patients do who have real disorders, quote unquote. Now, of course, the reason why we're talking about all this is because there are major consequences of stigma and discrimination. The whole framing of substance use and substance use disorders mean that how we frame it, how we conceptualize it, has implications for how we fund approaches to deal with it. Should we, for example, build more prisons? Should we incarcerate more people? Will that act as a deterrent to prevent these use and disorders? At the personal level, or should we spend more money on treatment, for example, and public health approaches? At the personal level, stigma can mean that people are less likely, through fear of discrimination, less likely to themselves acknowledge a problem, to disclose a problem to somebody else, and to seek help, sooner. So all of these things can affect both our public approaches as well as personally. These are some of the common dimensions of stigma that are studied. And I think it's important to recognize that stigma is multi-dimensional. It's not just a linear phenomenon, but rather there are multiple dimensions of stigma within the broad frame of stigma. One of them is blame. Are people to blame? Are they responsible for causing the problem or disorder? Can they get well? This idea of prognostic optimism or prognostic pessimism, or will they always be like that? And can they be trusted? The last two relate to dangerousness. One is actually dangerousness. Are they predictable, unpredictable, volatile, threat to my or other people's safety? And social distance. Would I have them, therefore, as a babysitter? Would I have them as a neighbor, as a co-worker, as a roommate? So why is it that addiction is so stigmatized compared to other social problems and health conditions and other psychiatric illnesses? Why is it the case? Now, I think it has to do with two major factors, as I've alluded to already. One has to do with cause and the other controllability. If we can say a condition or a problem is not somebody's fault and they can't help it, stigma tends to go down, it tends to decrease. We tend to have more compassion for people if we can say it's not their fault, they can't help it. On the other hand, if we say it is their fault, and they can't help it, they're just engaging in selfish, willful misconduct at the expense of other people, stigma tends to increase. Now, as I alluded to, I think one of the things that helps with these two dimensions in mitigating some of the stigma associated with this, not all of it, but some of it, is the fact that we've learned a lot about genetics in terms of cause. And I think this has helped overall in our understanding about the biomedical nature of these disorders. That, as I mentioned, on initial exposure, some of us are naturally protected just by virtue of our DNA. Other people are much more susceptible by virtue of their DNA and are not protected. They're more vulnerable. And this is just like other complex illnesses. So on that initial exposure, someone might get a very profound, rewarding effect that somebody who's protected does not get. They don't know they're experiencing it at a different level or to a different degree than somebody else, but they remember it very well because it has such a potent, rewarding, and reinforcing impact. And so they're more likely to repeat it. They don't know. Nobody plans to become addicted to a substance, to make that the top priority in their lives at the expense of all the other things in life, which is what, of course, happens. This is modulated in large part by genetics, which, as I mentioned, roughly accounts for about half the risk of the onset for substance use disorder. In terms of controllability, the other factor, genetics are the cause, as neurobiology is to controllability, we've learned again about the neurocircuits impacted by substance use. Here depicted reward, memory, motivation, impulse control, and judgment. These neurocircuits are affected radically in some persons from the severe end of the spectrum by chronic exposure to substances, not just functionally, but structurally. You don't have to look very long or very hard here down in the bottom right to see the structural impact, in this case to alcohol, of chronic exposure over time that leads to these structural changes. When we see images, both functional and structural images like this, which were only really viewable on autopsy before, we can understand why is it that somebody who promises, who makes this commitment to stop, to cut down to themselves, to other people, and means it, is unable to follow through because of these impairments in the brain structure and function. This is why, of course, it is in the DSM, it's a psychiatric illness. If it was a matter of voluntary control, it would not be a psychiatric illness. Now, it doesn't mean that everybody is completely incapable of changing or of regulating use. It is a matter of impairment and degrees of impairment as a function of chronic exposure over time. Some people can exert some control at some times, but it's extremely difficult to do so. And this is, of course, why we see what we see clinically in family members and loved ones when people make that promise to change, but find themselves unable to initiate or sustain it without proper treatment and support. So what can we do? As I mentioned, education, personal witness, and language changes are some of the ways in which we can address these problems. So here's a question. If we were then, I've made this case about this biomedical aspects of the genesis of substance use disorder in terms of its cause and controllability. What if we were to emphasize that more in our communications, in our education, would that reduce stigma? Well, let's look first at the mental health field, where this has been studied much more in a similar way to addiction. So this is a meta-analysis looking at 28 studies, which looked at studies that emphasized the biomedical nature of mental illness and looked to see its effect on different dimensions of stigma. Interestingly, when they emphasized the biomedical, biogenetic, as I mentioned, the genetics, biogenetic aspects of mental illness, they did see an impact on blame. So blame actually went down. But here's the interesting part. Other aspects of stigma, social distance, dangerousness, and prognostic pessimism, the belief that somebody cannot get well from a genetically influenced disorder, went up. So the opposite effect by emphasizing genetics, and we might want or anticipate, but it did have an effect on blame. So it reduced one aspect of stigma, but increased others. What about studies which have looked at controllability in the mental health field? Well, interestingly, when they've looked at studies in a similar way, this is a meta-analysis and quantitative review of studies that emphasize the neurobiological, the kind of the chemical imbalance of mental illness, for example. What effect does that have on stigma? Well, actually, they found that it increased stigma, once again, on social distance, dangerousness, prognostic pessimism. That is to say, they perceived that those who had this chemical imbalance could not get well. And it had no effect on reducing blame. So a kind of a neutral effect, but actually moving in the opposite direction of what we might think by emphasizing the neurobiological impact of mental illness. Interesting and slightly disturbing, but good to know. Now, what about drug-related impairment itself? What do we know in this field? Well, we actually just did a study last year where it was a US nationally representative sample where we were interested in looking at 6 different ways of describing drug-related impairment. Now, I wanted to do this study because, we don't know much about the impact of describing substance use disorder or addiction as, for example, a chronically relapsing brain disease, which is very commonly talked about as such, or as a brain disease, or as a disease, or as an illness, or a disorder, or as a problem. So we talk about these disorders and the drug-related impairment using language like this in different instances with different levels of emphasis at different times in different communications, including the National Institute of Drug Abuse, of course, has particularly been fond of the chronically relapsing brain disease. So we wanted to see, well, what effect does that have on these dimensions of stigma? So we actually used a nationally representative sample of the US adult population. There were 3,600 people sampled. And 600 people, both men and women, 300 men and 300 women in each cell, were exposed at random to a vignette describing somebody in treatment with drug-related impairment, where they were learning about the nature of their drug-related impairment being described in one of these 6 different ways. Okay, so that was the nature of the study. And then they were the study participants were asked to rate the person on the likelihood that, again, that they could get well, that they were to blame, whether they should be socially excluded or included, and were they dangerous. And what we found was very similar to what was found in those studies of mental health. Look at the top graph, first of all. You can see those 6 different terms. This first graph looks at blame. So when you look at the blaming dimension of stigma, you can see that when people were exposed to a vignette describing someone with drug-related impairment as having a chronically relapsing brain disease, blame tended to go down. So that greater biomedical emphasis tended to reduce blame. Conversely, you can see the kind of linear effect here over these different terms. On the right-hand side, when someone's described as having an opioid problem or being taught about their opioid-related impairment as an opioid problem, blame tended to go up. Now, interestingly, the exact opposite occurred when we looked at likelihood of recovery. Can someone get well who has opioid-related impairment? And should they be socially excluded? And are they dangerous? We found the opposite effect. So again, similar to those studies in the mental health field, we found that when someone with opioid-related impairment was described as having a chronically relapsing brain disease, the likelihood that they were perceived to be able to recover went down. Conversely, when you use less biomedical terminology, in this case, describing someone as having an opioid problem, the likelihood of recovery and improvement went up, as did their likelihood to be socially included and not to be perceived as dangerous. Interesting, the exact same terminology has different effects on different dimensions of stigma. More biomedical terminology reduced blame the most, but increased those perceptions of danger, social exclusion, and decreased perceptions that someone could recover. Less medical terminology increased blame the most, but decreased perceived danger, social exclusion, and increased perceptions. So it may mean, the implications of this, of course, is that there's no one single term that may be optimal in all instances of reducing stigma and discrimination. It may be that we need to be purposeful and choose particular terms when communicating in different instances. For example, to get people to reduce that self-stigma, shame that keeps them from entering treatment, we might want to emphasize the more biomedical aspects that reduces blame and shame. On the other side, when people are reintegrating back into society, into the workforce, we might want to talk about it less in terms of a chronically relapsing brain disease and more and use less medical terminology like an opioid problem or an opioid problem history. That tends to elicit less negative attitudes towards somebody's likelihood that they can get well or that they should be excluded or are dangerous. Interestingly, we also looked, as I mentioned, in half of those cases, The person in the vignette was described as a man, and half they were a woman. So we crossed it by gender of the sex of the participant. And a couple of things came out here which were interesting, was that women overall were viewed, compared to men, were viewed as more to blame for having an opioid impairment, and men were viewed as more dangerous and more likely to be socially excluded. Now, some of the implications of that, broadly speaking, mean that women may find it more difficult to acknowledge, admit, disclose a drug problem and the need for help. Men may find it more difficult to reintegrate and be included in society. So there's some potential sex differences, gender differences there in terms of the effects of having drug-related impairment across men and women that also do vary. What about, I've talked about how we might describe the disorders or the impairment itself. What about people who suffer from these impairments? What difference does that make if we describe people in different ways? Well, I think it's worth taking stock of what language is when we're thinking about terminology, of course. Now, language, it's fascinating. You know, I never really thought about this myself until recently, in the last 20 years since I've been really looking at this issue of language and what it can do, because it also makes sense. It's a standardized collection of sounds and symbols that trigger networks of cognitive scripts, activating change of thought that influence our appraisal, our attitudes, and our action, and it evolves over time. We don't use the same language. We don't talk about lunatic asylums. We don't talk about dipsomania. We did 100 years ago. Inebriates. We have different language today that's naturally evolved, but also it's important to change language when we know it has a negative impact and can cause stigma. And I think when we think about in the clinical and public health realm, there's this notion not just of stigma, but of clinical precision and accuracy. It's important that we use language that is precise enough to convey clinically meaningful and relevant information very specifically when we're talking about in the clinical realm, these disorders or any disorder. It also should have interpretation and utility. Is the terminology, for example, understood by most people in the way it is intended? Does it capture sufficient information to make it useful? And here, I think there's a potentially important distinction to be made between dependence and addiction, where a dependence, which is still used in ICD nomenclature in the World Health Organization International Classification of Diseases, has been dropped by DSM in the last iteration of the DSM, because in fact, dependence, although it is a part of addiction, is often used as a synonym for addiction, when some people can understand dependence as physiological dependence without drug-seeking, compulsive drug-seeking behavior. And of course, this nuance is important and can be important, whereas that distinction there in terminology has risen to the surface now. And hopefully there will be a change in ICD to drop the word dependent in favor of something else, maybe a substance use disorder. Stigma and discrimination, of course, is another aspect, is the terminology known to induce, as I mentioned, implicit and explicit biases that might undermine clinical and public health efforts. Now, we've got a lot of names, haven't we, in the addiction world that describe this array of drug involvement, alcohol and drug involvement, as well as people who have these problems suffer from these drug impairment. Here's a question for you. People with eating-related conditions are always referred to as having an eating disorder, never as food abusers. So why are people with substance-related conditions referred to as substance abusers or drug abusers or alcohol abusers, and not as having not as having a substance use disorder? It's an interesting disparity there that I noticed a number of years ago. Why is it that we never refer to people with eating-related problems as being food abusers, but we do when it comes to alcohol or other drugs? Again, I think it's just this cultural, this implicit, this disparity that we have culturally around these particular problems. Does it matter? Of course, is the question ultimately. And what's meant what's conveyed by that notion of calling someone a drug abuser or an alcohol abuser? Well, I began to think, well, maybe that implies that they're really just voluntarily engaging in willful misconduct. But they're abusing it. They really can control it, but they're just abusing it so for fun at the expense of other people. And if you contrast that with the notion of disorder or having a substance use disorder, maybe that might invoke the idea that somebody has a medical malfunction. And so we actually did a couple of studies where we randomly assigned, again, these two terms to see if it actually made a difference on stigma, attitudes and stigma. And in the first study was an interesting one because it involved experts in our field. So these were people who were mental health and addiction experts. These were people with top-level degrees and experience, PhDs, MDs, working in the field for a long time, who were exposed at random to a vignette that described somebody in a drug court situation who had relapsed and was up before the judge for a hearing. But in one vignette, they were described as being a substance abuser. In the other, they were described as having a substance use disorder. Otherwise, they were identical. And what we found was that at random, being exposed to the same person, description of the same person, but as a substance abuser versus having a substance use disorder, was more likely to induce more punitive attitudes among these top addiction and mental health experts. So they were more likely to view that person as more to blame, more in need of punishment, less in need of treatment. We did a similar study subsequent to that in the general public, in the general population. We found even bigger differences. You can see the magnitude of these differences here highlighted in these two bars. When someone was described as a substance abuser versus having a substance use disorder, they were viewed as less in need of treatment, much more in need of punishment, more of a social threat, more to blame, much more to blame for their condition or their problem, less likely to be exonerated, and more likely to be able to self-regulate. In other words, they were choosing to engage in willful misconduct. The implications here are that even among well-trained experts, clinicians in the field, the same individual, they have very different judgments depending on which term they're exposed to. And that abuser term and the abuse term that generates the abuser term may activate these implicit cognitive biases that perpetuate these stigmatizing attitudes that may have broad-scale implications for our approaches to addressing these endemic problems. Again, they reflect and affect our approaches. And again, referring to people as having a substance use disorder, which is now largely being adopted around the country in different systems, is a positive move, I think, away from this language, which we now know that can induce these biases, where even when we don't mean it, even when we mean nothing by it, it can induce these biases and evoke these schema associated with more punitive stance. Another big issue is this notion of dirty and clean. I hear, even at my own institution, I've heard on the floors of arguably one of the top hospitals in the world, people talking about dirty urine screens. These are clinical professionals talking about clean and dirty urine screens in clinical setting. You don't hear that language in any other area of psychiatry or medicine, but somehow the street language has made its way into our clinical and public health lexicon and culture. And I don't think we need a study to reach consensus that we should not be describing patients' urine toxicology screens as dirty. And that language obviously should be eradicated and dropped, along with, arguably, the abuse and abuser terminology. I think we have strong consensus and some empirical data now to show that this terminology is not helpful. It doesn't add any clinical precision to our communications clinically, and it's not helpful. So we need to drop that and adopt other terminology. So there are now a number of different prescriptions like this. I'm showing you right now from the CDC, from many other entities, which recommend certain language in favor of older language, which has now been shown to be more stigmatizing. So I think there is strong consensus on the idea of person-first language. The idea that's been adopted in the mental health field many decades ago, instead of describing someone as a schizophrenic, describing someone as a person first, who happens to have schizophrenia or suffers from schizophrenia, rather than calling them by the disease. The same has now been adopted, and I think there's strong consensus for this, to use person-first language in our field. Instead of calling someone an addict or an alcoholic, to describe them as someone who's addicted or someone who has an alcohol use disorder. And then to drop that abuse and abuser term and adopt more neutral terminology like substance use disorder that may imply and that reflects more what we understand now about the impact of these disorders in the brain, the fact that they change the brain and that produce this gradual impairment in the ability to regulate the impulse to use despite harmful consequences. And this, of course, we call addiction. This is why it is a psychiatric illness. A few years ago, we came up with this dictionary, which is housed at recoveryanswers.org. I think the point here is that if we want addiction destigmatized, we need a language that's unified and that accurately reflects the true nature of what we've learned about these conditions and disorders over the last 50 years, all the investment that we have put in. Happy to say that Richard Sates and myself, we went out to Budapest to present to the International Society of Addiction Journal editors. They adopted a consensus statement, which was published in 2015, which advocated for worldwide across all addiction journals that we should not be publishing any articles that have stigmatizing terminology. The American Bar Association has adopted similar recommendations based on the dictionary. The Associated Press, very importantly, had now updated the style guide in 2016 to recommend dropping stigmatizing terminology like abuse and abuser and addict and alcoholic in favor of more neutral terminology. That was an important, I think, change because if we don't read about it, if we don't see it in the media, we're less likely to perpetuate it culturally and to think about these disorders in those outdated stigmatizing terms. Google has also adopted this notion of changing our language. Happily, they linked to our dictionary and talk about now the importance of changing language around addiction. One paradox here is the fact that our National Institutes of Health on Addiction still have embedded within their names the word abuse. So this is a vestige, of course, of days gone by, and we've now realized that this term is stigmatizing, and it's likely to increase, not reduce, stigma. So, for example, we have the National Institute of Alcohol Abuse and Alcoholism, the National Institute of Drug Abuse, Substance Abuse and Mental Health Service Administration, etc. And now there is a movement underway to change the names of our National Institutes of Health. We started a petition with Faces and Voices of Recovery about a couple of years ago. And since then, there's now bipartisan legislation in Congress to change the names of these national institutes and federal administrations pertaining to addiction. The idea, of course, being that it is time for a change. We need to break the inertia and just make this change. I think if we do make this change, it will send an important message about the importance of terminology, as I said, which reflects and affects our approaches to these problems, and also can help to reduce the stigma associated with them. So in summary, and we're going to have some time for Q&A and discussion, I hope, over the next 20, 30 minutes, which is great. Reducing stigma in clinical community settings, I think there's some things that can be recommended based on the findings here and elsewhere. I think importantly, in our work and the things that we do every day, we can prescribe, we can model and reinforce universal use of appropriate person-first, non-stigmatizing terminology pertaining to these disordered and related problems. We can provide continuing education on the nature of substance use, service leadership, the practitioners, and all staff on the importance of addressing substance use disorders on clinical, ethical, humanitarian, compassionate care grounds, as well as health economic grounds, because we know that better treatment, prevention, harm reduction can all reduce the economic burden associated with these conditions, which is estimated to be somewhere around about $700 billion a year, a massive economic price tag that, if nothing else, that needs to be addressed better. Provide regular opportunity for interaction and exposure to recovering persons to help dismantle stereotypes and disabuse staff of faulty beliefs. I was reading at Cornell that when they train their residents there, they incorporate exposure to people who have or have had a substance use disorder to the residents. So they get to talk, converse, interact with, and understand more about what happened to them, what is happening to them, how they got well, how they recovered. To get that firsthand exposure. That social contact is very powerful, arguably the most powerful way of helping to dismantle stereotypes. And then I think also to in our own workplaces and workforces, to create a recovery-friendly workplace that openly and continually supports treatment and recovery for employees suffering from substance use disorder, including employing individuals with SUD histories and not discriminating against individuals who have that history. So with that, thanks for listening, everybody, and hopefully we can have some time for Q&A and discussion. Happy to set, you can have these slides, they'll be made available to you in a PDF. Email me as well if you want to get any of the articles. Happy to send any of those.
Thank you so much, Dr. Kelly. This was very informative, a wonderful talk. So we have a few questions here for you. Start up here. Any thoughts on epigenetics and the role of historic and intergenerational trauma?
Yeah. Well, we know, these are complex illnesses. So it's not just a matter, of course, of genetics or exposure, but through the developmental history of individuals, there are certain things which can elevate risk and affect the neurobiological, the whole genome development over time, including the effect of epigenetics and the environmental exposure over time. So that means trauma, traumatic experiences, abuse, neglect, impoverished environments. All of these things have been shown to increase risk. So these are very important factors to try and identify and, of course, prevent to the extent that we can, so that we don't have this interaction, because, of course, it's this genetic, it's just the gene by environment interaction that includes trauma and traumatic aspects of development that can turn on genes which would not be turned on, and that can elevate risk for substance use disorder as well as other psychiatric illnesses. So those those epigenetic factors are also crucially important, and those are things that we can do something about.
Thank you. The next question is, your slides say SUD-specific education and training. For clinicians, what about broadening to include other forms of stigma around sex work, etc.? And would you advise inclusivity or specificity?
Well, inclusivity or specificity, I'm not sure about what, but I think in general, the more that we can educate people, empower people with knowledge about the nature of these disorders or the nature of other problems. Sex workers often are working in sex work because of a substance use disorder and related to substance use or other kinds of psychiatric illness. Again, so all of these things that threaten people's well-being, public health, and public safety are important to educate and empower people through education. And I would certainly advocate for that. We see that with substance use disorder. I think we see that in other areas as well.
Perfect. Okay, thank you. The next question is, I find it stigmatizing to talk about the effect of substances as pleasure and reward. Why not use the science and talk about it as salience?
Well, it's salient. I think the reason why they are salient is because of the reward. It's not just about reward, but also relief and performance. Don't forget, there are four main reasons why people use, which is to feel better, to feel good, to do better, or because other people use them. So it's not just about reward and reinforcement, but relief, negative reinforcement, and performance enhancement. So there are different reasons why people may use, and that can change over time, of course. I always talk about, the four main reasons why people start using substances are the four main reasons why people stop using the substances. In other words, they start to feel good, to feel better, to do better because other people are doing it. Stop to feel good, to feel better, to do better. Because all substances on the exposure to the person, they actually do a 180-degree turnaround. What was once the best thing in the world turns out to be the worst thing in the world, and except the train has left the station and they can't stop it. And of course, this is the nature of addiction. But salience, of course, increases because of their impact. I hope I'm not sure if I've answered that question right for that person, but forgive me if I haven't. But that's the way I think about it.
Okay, thank you. The next question is, does this include understanding the neurobiology of trauma and the way it creates a vulnerability to SUD?
Well, again, I think we have to look at all these risk factors, including early exposure. So traumatic experiences can elevate risk, as can early exposure. All these things can be independent and synergistic in multiplying the risk over time as people go on particularly in their adolescent years and early emerging adult years, where we see these the roots of addiction take place. So yes, the reverberations of trauma in the neurobiology and the genetic genome, all these things elevate risk, as well as early exposure. Other kinds of environmental risk factors are again, they're independent and as well.
Okay, the next question is, I think there may be a confounding factor in how society understands certain buzzwords. Is chronically relapsing brain disease a newer term that not many people understand at this time? If it became more known, would it change these dynamics?
Oh, it's an interesting question. I don't know. Maybe. Certainly. I think it's descriptively quite accurate in the sense that it is chronic, it tends to be relapsing, and it does affect the brain. The question is, I think, even if it's true, what's its utility? So I think this question of utility becomes important in terms of relative emphasis. How should we describe these disorders, to whom, when, and in what way, in what context? Because even if it's true, it may, as I mentioned, as we've shown and as we know, it can induce these different elements of, it tends to reduce blame, but increase other kinds of stigma. Now, it may be, the questioner is maybe asking, would that change potentially with greater exposure of that, that they would, maybe, I don't know. It hasn't happened in the mental health world, mental health field. When they emphasize the biomedical, it does tend to reduce blame, but tends to increase other elements of stigma. I think what we need to do is, when we talk about these disorders, I think it's okay to talk to them as diseases which affect the brain or disorders which affect the brain's neurocircuitry. Those are facts, but they are genetically influenced, etc. That does tend to reduce blame in families, in individuals themselves. But we also need to talk about the fact that these are highly treatable conditions, highly treatable, and most people will actually achieve sustained remission from them. We know from the latest National Survey of Drug Use and Health that 75% of people who meet criteria for a substance use disorder eventually will achieve remission. So that's a very good prognosis disorder when we compare that to other psychiatric illnesses or other kinds of medical conditions. And I think putting that package together, yes, they are genetically influenced disorders that affect the brain neurocircuitry, that reduces, that has this impairment, that induces this impairment in regulation regarding substance use. But they are treatable, and most people will actually achieve sustained remission. So we need to put that together, I think, to help create the whole picture of reducing the blame, but hopefully increasing the prognostic optimism.
Okay, thank you. The next question is a two-part question, so I'll ask the first one. Did this study look at the effects of using multiple descriptors in the same vignette?
No. So they were all randomized between participants. So each study participant just got one version of the vignette that was describing the drug-related impairment in one of those 6 different ways. So between subjects.
Okay, and the second part is, would using these descriptors interchangeably affect the way people are viewed?
Interchangeably. Well, yes, I think so, because that was the point of the study, is that we wanted to expose participants to different types of ways of describing the drug-related impairment. And of course, what we found was that we did find different effects depending on which way which way their drug-related impairment was described to them by treatment staff. So when the drug-related impairment was described to them as being a chronically relapsing brain disease, participants then viewed that person being treated as less to blame for having their drug-related impairment. If it was described to them as a opioid problem, they viewed that person as more likely to recover and to be less dangerous and to be socially included as opposed to be excluded. So it did seem to matter which way, in terms of perceptions of inclusion, social exclusion, dangerousness, and blame, etc., depending on what they were exposed to.
Thank you. The next question is, do you feel that those who have been through the recovery journey are willing or more reluctant to change the language? I don't know. I mean, I think most people will, I think most people who are in recovery, I would argue, are compassionate and want to make a difference. They've experienced a lot of positive change themselves and oftentimes want to give back and want to do the right thing. I'm generalizing here, but I think that's my impression. Regarding language, I think as we all understand more about the power of language and the power of words in how that affects people's perceptions, I think then more people will start to adopt different language. Now, the other thing is that culturally, of course, these things take time to change. It's not going to be an overnight matter. As again, we don't talk about lunatic asylums, inebriates, dipsomania, the way that we did 100 years ago. So things do change, language does change. And I think the important point here is that in our clinical public health communications, that we should not be using language that is known to be stigmatizing and that is to be contrary to the kinds of clinical and public health goals that we have, which is to try and get more people better access to treatment and get them treatment sooner in the clinical course so that we can destabilize emerging addiction patterns and improve their public health and their own trajectories as well as the public health
of the country. So it does take time, but I think it will infiltrate gradually into society, diffuse into society as we start to change our language and terminology at the clinical and public health level, because that will start to be disseminated through the media. And as people get exposed to it, language will change, including among people in recovery.
Okay, the next question is, what do you think about the separation of NIDA and NAAA as reflective of how we tend to separate alcohol, a drug, from other drugs?
Well, that is a big question, isn't it? We don't even talk about alcohol as a drug. It's like alcohol and drugs, right? And of course, there are many different historical cultural reasons for that. And, we tend not to want to think about, culturally, don't want to think about alcohol as a drug, and that we are actually taking a drug if we are consuming alcohol. We don't want to associate it with that in our culture, even though, of course, it is a psychoactive drug, and that is responsible actually for 75% of all addiction cases in the United States. Kills 10 times more people than all illicit drugs combined. So worldwide. So it's an artificial distinction. It's culturally based. It doesn't make sense from a scientific phenomenological standpoint, because addiction to alcohol has the same process as addiction to other drugs. Now, the profile consequences can be different across different substances, but essentially, I think the questioner is correct in that, the implication of the question is that they're not really different, but they're culturally made distinct because of the culture and probably industry influence as well, as the alcohol industry does not want alcohol to be considered a drug, that people are using a drug if they're drinking alcohol. So there's a strong influence there, I think, from industry to prevent that from happening.
Thank you. Okay, so the next question here is, has there been any research on specific words in languages other than English, especially languages commonly spoken in the US, such as Spanish?
Not that I know of. It's a great question. But I know that many people around the world now have taken up this mantle of stigmatizing language and terminology, and I've been in contact with many of them around the world in different languages, in French and German, for example. I've been in contact with people with Spanish, or that is a major one, of course, around the world. But be interesting to look at that. I haven't seen studies, and I haven't seen studies in other languages that have done this kind of randomized type of design to look at how that may be influential in other languages. But I would expect the same kinds of thing. I know there are, again, pejorative language, discriminatory language, which pertains to drug use disorders in different languages. So I would expect the same results, but I haven't seen those studies.
All right, the next question is, are there efforts to address stigmatizing language within the general public, Justice Department, or similar non-healthcare settings?
Well, certainly in the criminal justice system, yes. There are strong advocates in the criminal justice system to reform the criminal justice system and to address, of course, substance use disorder as a health problem rather than a criminal justice problem, and who have advocated for, and I've given loads of talks, dozens of talks to judges, to criminal justice system professionals, just like I've given today, to help them understand. And many, there's a mixed bag in there in terms of people who want reform and those who don't. But again, trying to educate the criminal justice system and law enforcement around the importance of language and the way that we think about now and conceptualize these problems. As I mentioned at the beginning, culturally we are making a shift in the criminal justice system at the frontline law enforcement level, as well as other areas. I expect that to continue as we see this trend towards a broader public health approach which would include decriminalization as well as providing more and better quality prevention, treatment, and recovery support services.
Perfect, thank you. The next question is, how do you think a 12-step program influences stigma with substance use disorder?
How it influences stigma. I'm not sure. Sometimes the question arises is, I'm not sure if this is the intent of the question here, but the nature of the self-identification in 12-step programs, like calling oneself an alcoholic or an addict, is that, stigma, adding to the stigma? I'm not sure if that's the intent of the question. But again, I think I wouldn't legislate or prescribe or be the language police for how people refer to themselves. But I think as professionals, we should not be using language or modeling language or using that we know to be stigmatizing. And that is likely to induce negative biases. And again, I think culturally things will change. Things change over time. People will change how they refer even to themselves. I'm not sure if that's the intent of the question. I apologize. Feel free to ask again or clarify if I missed your point.
Okay, and one other question here that I have for you is, what is the role of academia in helping reduce the stigma surrounding addiction?
Well, I think there's one clear role in our training programs for future clinicians, mental health workers of all stripes and flavors right across the board. We need to do a much better job in our training programs, our education and training programs for clinicians, as well as, I think, in our general exposure to, psychology classes, health classes that are addressing anything to do with health. Listen, this is the top public health problem. I don't think anybody would debate that top public health problem in the United States: addiction and substance-related conditions, alcohol, opioids, amphetamine, methamphetamine, cocaine. These are undermining all of our healthcare efforts, and we need to do a much better job of incorporating these conditions there for screening, for assessment, for treatment, empowering clinicians to make a difference at all levels of healthcare and public health oriented services. We have a duty, I think. It's in our own best interest as a society to improve the public health and reduce healthcare costs and other costs around it. It makes a lot of sense. We are far behind the times. We have made strides in medical schools, for example. Now they're starting to incorporate addiction training among general practitioners and other practitioners coming through the ranks. So that's a good thing. I think we need to keep our foot on the gas for sure to ensure that all kinds of public servants who are interfacing in public health settings that are well equipped now to screen for, assess, and address these problems.
Thank you. And relatedly, what steps can be taken to involve people with histories of addiction in research?
Well, I think, I think advocating for explicitly that, maybe pointing out that, people with lived experience are encouraged to apply. It's something that we've not done in the past. One of the things we do in research, of course, is we do consult now much more. There's a stronger ethic now of consulting with people with lived experience. The population, this has historically, sadly, not been done. Of course, we're now more enlightened in this regard, and the importance and significance of including the voices and experiences of people who have that lived experience in research, this idea of community-based participatory research, incorporating their voices, having people with lived experience, informing the research process. That has started now a long time ago, thankfully. But I think pointing out, as I began to say, that people with lived experience are encouraged to apply, actually making that a point of our ads so that we can start to incorporate more people in research who have lived experience. I think that would be a very good thing.
Thank you so much. And we've got one last question, Dr. Kelly. How do we get started in changing the language in our workplace, especially when employing recovered staff who use the stigmatizing language themselves?
Yeah, again, these are all great questions, and in different contexts. I think the same broad principles apply. Is that, is to educate, and I'm working with kind of the federal few federal institutions right now to look at the workplace and look at the workforce and recovery-ready workplaces and try and help them understand the nature of these disorders and conditions, who's at more risk for pain management, do the jobs. They're more likely, like in construction, to cause more injuries and chronic fatigue and that can lead to opioid use and so on, and to educate employers around that and employees around that. I think that's a critical aspect of what we should do. Again, I think the same principles apply. You need to educate at the top echelon, get buy-in at the top levels of different workforce institutions and companies to make them aware so that it can start to be implemented across the entire agency or company and become a part of the workplace culture.
Well, thank you so much, Dr. Kelly. We really appreciate your time. This was a wonderful and informative talk, and we hope that you have a really great rest of your day.
Thanks, Riley, and thanks, everybody. Really appreciate the great questions and great discussion. Reach out to me if you want any of these papers, and thanks so much for having me.
Thank you so much.
Bye-bye.